Let me just, I'm going to talk for maybe 10 minutes about the DataDirect tool specifically, but then I think for another 5-10 minutes, I can demo any aspects of the tool or a documentation website, wherever you guys want to take it. So it's most helpful to you. So I love that we did the introduction because it's a hugely diverse group from lots of different departments. You probably have interacted in a lot of different ways with central data tools. If you have used DataDirect before, hopefully I'll tell you something new about it. If you haven't, hopefully after this you can try it out. And the one takeaway about DataDirect is it's a homegrown tool. It's supported by a small, nimble team. And so when you have features that you don't see that you would like added to DataDirect, or data that you would like added to DataDirect, we have a very quick turnaround because it's a small localized team. So that's the one takeaway. So I'm going to talk about how DataDirect can really enable augmenting all of the work you guys do with mobile technologies. So we sit in Michigan Medicine's Office of Research. So we're one of the units there, like IRB, Fast Forward Medical Innovation, the Central Biorepository. This is one of the strategic investments from about 10 years ago when leadership in Office of Research said, you know, there's a lot of data. A lot of it's electronic. It's really hard to get at. All throughout the data life cycle, whether it be looking at a feasibility assessment of how many patients we see with a particular condition for a study, all the way to a need for sharing data. Now there's an NIH requirement that data be made available for reproducibility, all the way to storing. How long should I store it? Where should I store it? And so the Office of Research created the data office. We used to be called the Honest Broker Office. So we still serve an honest broker function, but you could think of it now as the research data warehouse, and then DataDirect that sits on top of that, as well as a group of programmers who can pull data for you. So the various needs that you can have met via the data office and DataDirect tool specifically is cohort discovery. A lot of people use these tools for large retrospective observational studies, or to design a prospective study based on if you have a large enough N, are there enough patients for an industry trial? Could we start to use them in a recruitment way? There's recruitment features in the tool itself. There's a real intersection with the precision health efforts to expose which of our Michigan Medicine patients also have genetic data, mainly genotyped. Some has actually been fully sequenced, that you can use together their genetic information with their medical record information, with their mobile device data. You can start to glue all these pieces together. And DataDirect is supposed to be a go-to place where you can at least see what's out there and what's possible. And then we do a lot of work helping Michigan medicine data map to a national standard so that it can be used in network-based research. So if you and your PI you have a study with Duke and with Mayo Clinic, everyone has Epic, but we all implemented it differently. So our data needs to be mapped to a standard so we can more easily share it. And then a lot of what we do is help determine, based on what data you need, who could have it. So if I just need a limited data set, I need dates, but I don't need someone's address or their first name or last name. Could you guys pull a limited data set for me? Can I give this data to my fellow that I'm working with this semester? I have a visiting med student. Could they have access to DataDirect, or could you pull data for them? Some researchers say to us, could you just give me all the data? I don't want like just a finite set. I want to build a machine learning algorithm. I want to build a predictive model that's going to tell me a given outcome. So I need all the data. Can you just give that to me? Can I store it in the cloud? Can I store it on Dropbox? So these are the kind of nuances that in addition to what data they need, it's all these different flavors of who can have it, where it has to be stored, what requirements are needed. And then of course, linkage, how can data sets, and that's really what today's about. That's what this whole mobile technology core is about, and MCN. How can I link data I have from a Fitbit or a sleep study with the patient's diagnosis in my chart, or with social economic status data from their geolocation data, or surveys we ask them to fill out as part of prompt or as part of the intern study? How can I link all those together so I can get a fuller picture? So we're not IRB and we're not compliance, but we do everything through those two lenses. And so that's a lot of why people come to us and they'll ask us, what kind of IRB application do I need if this is the type of study I want to do? Or if I'm going to share this data with GlaxoSmithKline after I do the collection, they're going to pay me for those findings. What consent do I need? What data sharing agreement? Who in innovation partnerships do I work with? I know we have someone on from that. In order to make the partnership strong and to make us able to do those things. So our main customer is the Michigan research community at large. Increasingly, networks across the country are things we help researchers participate in, and then industry is another one. So I'll talk most about DataDirect. And if you haven't used it before, the main thing to know is that there are two main modes, if you will. There's, without IRB, you can do cohort feasibility. You can get a good sense of how many patients meet some inclusion-exclusion criteria. You can also see what is the race breakdown, what are the insurance type breakdowns, all without IRB. It's just aggregate counts. With IRB, you can download your own patient row level data export to do your analysis. So there's actually two versions of DataDirect, and this came out of the Precision Health Initiative because we didn't want everyone to have to get a level 2 account in order to use this really powerful tool. We wanted those who were outside of the firewall to be able to do this in a very safe and efficient way. So there's two different URLs you can see here, and you don't have to write it down. I'm going to share these slides with Nicole and Victoria, but and there's the second to last slide has a ton of links on it that you may need. But just know there are different features in these two tools. They work very, very close, but they're not identical, because in the level 1 version that sits outside the firewall, there are dates, but they've been shifted. So you can still do time relationships, but the dates have been shifted and all identifiers have been removed. The level 2 has real dates. It has other identifiers. If you've been approved for recruitment, let's say, you could have access to patient email or home address. But that's the 2 versions. Sometimes it's called the de-identified version. Sometimes it's called the Precision Health version. That's the level 1. But I'll share with you a couple different features. In general, DataDirect is a tool to get at structured data from the electronic medical record. So this is the data go back, sometimes to 2000, depending on what type of data. We're really good at billing data. So encounters, dates of admission, dates of discharge, those data go back pretty far. Lab data goes back pretty far. Some of meds, 2004, 2006, they start to be a little bit more robust and less missing data. Those are still before we got Epic as an EMR product, but we've been able to glue together all the different electronic systems that Michigan's had over the years. And then as I mentioned at the top of the talk, there's lots of opportunity to continue to enhance the tool and make it more usable. So I'm constantly asking groups like yourselves and other research communities within Michigan, what is still missing? What do you need? So one thing we heard a lot was socioeconomic status data. That our only way to kind of adjust for SES variables in the data we had was those on Medicaid, you could use as a proxy for those who are more at disadvantage. We built in two types of data. One is data that we generated through geolocation information. So that's taking each patient's street address, determining the latitude, longitude, associating that with the census block ID, and then because of national data sets, and many of the data are actually curated at the Institute for Social Research here at Michigan, but they make available things like household income, highest education level, crime, access to parks. Over 100 different data elements are available from those geolocation data. It's not the individual patient's home income or education level. It's the block in which that patient lives. This is the average household income. This is the average percent of households that are immigrant-led or female-led households. It gives you a real sense of, man, these two patient populations with hypertension did very differently. Could there be socio or economic factors playing into those different outcomes? The other things, a lot of our colleagues, I don't know, Rima, if you've used this, but questionnaires that patients get answered when they come to see their primary care physician, things like food insecurity. Did you have to forego medications this month because of cost? Did you have to forego payment of a utility or payment of rent or your mortgage? And again, a sense of some of the factors impacting a patient and possibly their health care. Some researchers said, hey, every time I go in, I have to recreate, asthma, or I have to recreate some phenotype or cohort. Could you just have starting populations I could go in and grab? Like, I just want all surgical patients because I'm doing anesthesia and I don't want to have to type in every operating room in order to capture those. I just want all primary care patients. I want all diabetic patients. And so if there's a particular population that you and the researchers you support have to build again and again, we can build that as a starting population, or what we call computable phenotypes in the tool. We also just heard there are certain data types that we weren't pulling over from MyChart that are really helpful. The family medicine researchers, some of them have a lot of patients hearing impaired, and they wanted to know in the cohort definition, which patients prefer ASL as the language to conduct the visit in. So we were able to build that in up front. Researchers wanted ejection fraction in a structured field. They didn't want to have to go to the echo report and read it. Same with pulmonary function tests. Some wanted to know, I just need to know who's enrolled in the portal so I can potentially use the portal as a way to get questionnaires or to recruit. Who has a Michigan PCP, pregnancy outcomes, death data, who's on a given inpatient service. Think of what you and your researchers might still struggle over with the DataDirect tool, and we could look at building that in. So right now we have really good medical data going back, 15 years of clinical data from the EMR. We have I think we're close to 100,000 patients who consented to the Michigan Genomics Initiative study, and we have genotype data about them. Increasingly though, and with your partnership, we're really looking to round out some of the other data types I talked about that will give us a fuller picture of the patient. And so certainly incorporation of mobile health technologies, whether it be watches, monitors, is going to be an incredible asset for better able to understand the patient. And I think the role that the Research Data Warehouse, the data office plays is having a way to centrally link those by a common patient ID, by a common encounter ID. And so researchers can better analyze those findings. So I mentioned some of these, but when in doubt, I just encourage you to reach out to us and say, do you have this data? Where's the prompt data? Do you know if I can add this current data? Like yesterday we got asked, for sleep studies, the data, the findings and the measurements from sleep studies live in a PDF format. is there any way to get a data dump from the vendor Philips so that we could have those important measurements about a sleep study in a structured field? That's some of the things we can help you work on. And then here, save this slide. I'll share them with Victoria, links to the different DataDirect tools. The documentation site is really helpful. It tells you where the data came from, if any like mapping or cleanup was done with the data, how far back it goes. I think it's really helpful. And then the email address to set up a consultation with us. So I'm going to stop there and stop sharing, see if there's any questions, see if I can demo any of the tools for you all. Oh, thanks. I saw Gabriel has a question in the chat about dates being shifted. And I'm just reading Emily's real fast too. Yeah. Okay, great question. So we call these obfuscated dates, but essentially what our programmers have done is taken the data, the database that underlies the level 1 version outside the firewall and shifted all the dates within a given patient's record all in the same direction. So maybe it's 1 week, 2 weeks, 3 weeks, or maybe it's 1 week back, 2 weeks, but all of the dates within one patient's record will be shifted the same amount. So you can still tell age at a given episode. You can still tell when was the antibiotic started and when did their white blood cell count change. The dates are all, the time between them, the temporal relationship is preserved, but they're not the real date. And so it's not PHI. It's not one of the HIPAA data elements. Between
so is that,
yeah, go ahead, Gabriel.
yeah, so is that different per patient? Because if you're looking at a cohort and the dates are shifting in different directions, then that affects the analysis, right?
It could. I mean, it depends if you're studying. So day of the week is maintained. So if you're studying admissions to the ED on a Sunday, it'll still show that that patient was admitted on a Sunday. It'll have a week before the real Sunday they were, or a week after, and all the dates are shifted, so it won't affect your analysis within that patient's record. You will still know that the patient came back to the ED within 15 days of that admission. There's different ways that those dates are shifted between patients, just so if you figure out the pattern, it won't apply to any other patients. It's really just a way to protect. But within a data set, you would treat it like any other date. You just can know if the file gets out there, those aren't real dates, those are fake dates. Does that make sense, Gabriel, or Emma, or Emily, I'm sorry, does that answer the question?
Sure. I just have a couple of follow-ups.
Sure.
In that. So the amount that it's shifted, are we talking for everyone, it's more in the time frame of like weeks, or are some people shifted like months or years?
Yeah, it's either 1, 2, 3 weeks forward or 1, 2, 3 weeks back.
Okay.
And so again, seasonality was another thing that, I mean, especially this became especially relevant during COVID. People would say, I don't want the date shifted 6 months because I really want to know in March 2020, what was the patient's immunization status? So it might be a week or 2 off, 2 weeks off, but it's 7 days or 14 days or 21 days. So it still maintains day of the week and it still maintains seasonality. It's just a way to not use real dates.
Okay. And then their age at the time of like an encounter, for example, should be accurate. So if it's like shifted to before their birth date, their age should still reflect like if
their birthday's been shifted to the exact same amount.
Okay.
So their age to the day is the exact same.
Okay.
And if you need real dates, some people need real dates. You know, if you think of some of the studies like Jenna Ween's C. diff study, she needs to know who's in the hospital today with these vitals because they might be at risk for C. diff and I need to start some antibiotics prophylactically. then I would use the level 2 DataDirect tool that has real dates in it. But for the vast majority of users outside the firewall, they don't need to know it was March 13th. You know,
Right.
it could be March 20th. It wouldn't make a difference to them. They just need to know within a given patient, what was the time length between this, how many days before that, when were they diagnosed, when were they, you know, they need to know those relationships, but not the real date.
So you said it's consistent within patient, so that's even across all views. So if I'm
All
downloading
of you.
medication data that has a certain like prescription date, that should be shifted the same amount as their encounter date that might have been 2 months
Exactly.
previously. Okay.
And again, with their birth date, with their whatever anchor date so all dates within a given patient have had the same algorithm shifted. So you could still do everything. Yeah.
Okay. Thank you for that clarification.
No, I know. I say shifted dates and then people are like, that sounds very messy. And it sounds like my findings won't be usable, but right.
Yeah. Right. Yeah.
But of course, I am not smart enough to do this. There's really smart people who do these algorithms. I can just almost explain them in English, but not well. As you can see.
Yeah. No, that makes sense. Yeah. I have
Yeah.
a cohort that I downloaded 2016 and onward. And then I also compared dates, you know, within like 30 days of
Yes,
diagnosis and that kind of thing. So,
yeah.
okay. Just good to know. Thank you.
It looks like Victoria and I both had a question around geolocation. So is the geolocation based on primary residence or mailing address, and what happens with the changes, or with someone that has unstable housing or is homeless?
Great.
And is that tied to social determinants of health?
Gabriel, you're asking all the hard questions today. I love it. Yes. So it's tied to current street address. And yes, it's associated with census data and other national efforts that look at, it's not necessarily every 10 years. There are updates to census data and some of these SES data that are more frequently collected than every 10 years. And so what you'll get if you download these, and yes, these are the social determinants of health, SES data, however you want to call them, based on geolocation. And they're proxies, they're not that patient's, but for each patient, you'll get a percentage of households on that patient's actual street block that had these characteristics. And so what you'll get if you download the geolocation views is you'll get one patient, and let's say in the last 5 years, they have moved 3 times. You'll get the social determinants data associated with each of those addresses. And so, yeah, and so if every time in my chart, we captured a new address when they came in, each of those street addresses has the associated SES data. Does that make sense, Gabriel?
Yeah, that helps. But what happens when someone is homeless?
I don't know. I don't know what their address looks like in my chart. If they're homeless, we could identify. There's also prison. Some of our patients have a state penitentiary, and I don't know if there's, you know, the longitude of the prison has SES data. It probably does. I don't know. But that's a great question to say for some of the less common, like either a group home, a homeless shelter, a prison, some of these different things. I don't actually know. I don't know what those look like in the registration system of my chart, but we could look.
Yeah, that'd be interesting to find out from a DEI perspective.
It absolutely would. And yeah, and I know our population, Michigan medicine population, isn't especially disadvantaged, though we do have homeless, we do have prison, we do have, and of course we have then, you know, adult care facilities, things like that, that are nursing homes, other group living situations that I suppose if there is a street address, you could still do the geolocation assessment, but But yeah, that's a great question. And Rima Kadri put in the chat the NANDA website that gives you a little bit of a background on the data types, how they were collected. Certainly, if you use those data, reference that website that Rima has there. It's got some really interesting information.
It is so cool. We're using that for one of our projects. It's very much focused on health equity during COVID. And so we, based on address at time of service, we have these NANDA elements that tell us where people lived, and the NANDA data set gives you those tie-ins to your social determinants of health, like, race, income. For us includes also things like broadband access, because of, again, we're concerned about telehealth during COVID. So it's incredible data. It's big, scary data, but it's been critical for us as we try to piece together which populations were affected by telehealth expansion during COVID.
That's awesome, Rima. Do you know anything, Rima, about Gabriel's question with patients whose status is homeless or
I
transient?
can't speak on that, but I can say that what we have noted is, because we have multiple years of data, that we did have to kind of go back to Arena and others at the data office and say, hey, but what if someone moved? And so I think we have, in essence, like nested, where people have multiple addresses, and so therefore their NANDA data shifted within our time period. So it does get really complicated if you're doing a big retrospective poll and you're getting people who would be transient, whether a weekly, daily basis, or whether it's just you have multiple years and people moved. It is something you need to consider.
Yeah. Thanks, Rima. So I want to say something about future studies and how to think about this. When I think about wearables data, I think about incredibly granular, large data sets. Nicole notes this all too well, like something that's going to tell my heart rate every 10 seconds. It's going to tell my blood pressure, and it's huge data sets. While if the goal of your study is to centrally locate those data for other researchers to use, the research data warehouse and data office are the place to go for that. It doesn't necessarily mean we'll house the raw data elements themselves from the wearable devices in the research data warehouse. Likely we'll have metadata about what's available that's discoverable in the data tools, in DataDirect and things. And if you say, yes, I'm interested in physical activity, sleep, and depression, self-reported depression from this study that was all collected on the Apple Watch, let's say, you could identify that cohort, the time frame in which you want the wearables data, and then we could connect you to the wearables database where those granular, huge data sets live. So I think, if you have a data set, you've been working, prompt is already in the level 1 DataDirect. You can look up how we represented the wearables. If you have suggestions on how to better represent those in a self-serve tool, let us know. But I think we'll probably have more metadata, so you can at least see what's available on which patients for how long. If that's what you're after, we can connect you up with the granular data. But as Nicole knows, it's overwhelming when you look at how much data is available from a device.
Do we have time here for you to give us an example of like pulling a cohort in DataDirect? Like, let's say we look for a specific social determinant of health and they have heart rate data.
Victoria, you tell me.
We do. I wanted to make a quick announcement just because of the conversation around social determinants of health. I put a link to the agenda in the chat, and on the agenda there's an open invitation to a I don't know if it's a conference, it's a biannual meeting, I guess, but it's a 4.5 hour meeting that has a lot of presentations and such. And so I just wanted to like share that so that you guys
Great.
can go if you want to. But I would say absolutely go ahead and do a show and tell, Erin.
Okay, great. And please know I'm the worst person to do this because I work with smart people who do this. So let me show you, I'm going to log into, so if you see a DataDirect login screen here, I'm going to show this because this is where the prompt data live. And we're working on exposing the prompt data in the level 2. But right today, go to the link I gave you that is the Precision Health Build tool that sits outside the firewall. And I'll show you how to do that. This version is level 1. So it will send me a Duo note to authenticate. And then I will name my query. It's a test. Are you guys seeing create a new query on the screen?
Yes.
Okay, good. Sometimes it doesn't advance. If you have an IRB, any IRB for which your unique name is a study team member will be in this drop-down list. I'll pick a fake study. And from there, you can either choose cohort that's going to give you aggregate counts, or you can choose de-identified data download. So this is row level data, 1 patient per row, shifted dates, as we talked about earlier. I'll choose that one. And I'm going to create a new cohort. So again, I could start with a defined population. I could start with, let's start with primary care patients. And I'm going to click add. And it's going to, from our starting place of 5 million unique Michigan medicine patients who have a medical record number, this is going to say, of those, 251,000 are considered primary care patients. We're a tertiary care hospital. A lot of people come here for specialty services only, go home to where they live and see their primary care physician. 5 million is not our active patients. Our active patients are just below 2 million, meaning they've had at least one encounter in the last 18 months. 5 million is anyone who's ever had a medical record number. It could be someone from the early 90s who had a medical record number, they never came in. So 5 million is not our active patients. And then I'm going to look for a diagnosis of depression. And I'm going to scroll down here. I can pick any of the ICD-10 codes that I see. I can pick, I can have it set to all sources. So look for depression among facility or professional billing. It might just be on the problem summary list. It might be in their medical history. It might be the reason they're there that day, the visit diagnosis. I also say, sure, bring in ICD-9 codes in case these data go back before 2016. And if I want to refine this list, there are X's along the right hand I can filter down. I'm just going to, for the sake of demo, cast a wider net. And then I'm going to go down to the output view selection. So once I have my inclusion exclusion criteria, and I can go into way more detail here if you want any particular, I can then say, all right, I am interested in downloading the following types of Excel spreadsheet data about these primary care patients with depression. This, just to show you demographic, is where we have some of the geolocation data. It's where the Michigan Death Index data are. That's date of death, cause of death. If they died in Michigan only though. Patient race data. And I would just click on any of these and then select the columns that I'd like to see in my output. And we have DID date, again, to remind you, this isn't a real date. This is a date that has been shifted. So again, death, like birth, has been shifted in the exact same amount. So you can tell age at death, things like that. That's all under demographics. There's procedures, Medicaid, all different things you can download. I'm going to come down here to wearable. And these are the various views or output types you can download. So for prompt, you can see we have about 8 or 9 different views. We have activity, logs, we have the daily data. The daily data is things like calories, BMI, distance, floors, elevation, all the things that it's monitoring on that Fitbit, summed up as a total for a day. It's not every single count. Food and calories for the day, not each meal. Same with resting heart rate, sleep log summary. I'll show you what those look like. Again, this is minutes after wake, minutes it took the user to get out of bed after waking. This is how granular you want the data. How much time they spent in various levels of sleep. This would make sense to Kathy. This is health kit activities. This is energy burned, exercise time, and then there's health kit. I can't remember what this one is.
It's for Google Fit for people with Android. Yep.
Thanks, Colin. This is your study. You should be doing this. Yeah.
Yes.
So here's, again, to better understand what, the start-stop times were, what device was used, things like that. So what this would do is this would spit out data for any of these 66,000 patients who were in prompt. Does that make sense? So another thing here is survey data. There were surveys given as part of prompt, so you can look at that against patient-reported outcomes, if you will. The EpiQ survey is a 25 instrument survey on what you eat, how much you sleep, your family history. There's also pain severity that comes from the Michigan Genomics Initiative. And then questionnaires. I have to look at what this is, if this is that primary care questionnaire. I'm not totally sure, but I can find that out. So I'll stop sharing there for just a second, just to see if there's any questions or anything I should highlight, or if you guys want to play with it yourselves and then come back. At the bottom of the DataDirect screen, whether you're in the level 1 or level 2, it says email for support and feedback. That will bring you right to, an email that you can say, hey, I would have expected to see this here, or I got 0 and I know there's patients in here. Any kind of thing you're doing, it's kind of like a real-time report it, just so you can remember it and not have to pop out to Outlook.
Yeah, I want to clarify a few things about the Fitbit data.
Please do.
Yeah, so I know some of the categories say like food tracked and things like that. We don't require our participants to do any of that, so there's probably a small amount of data for that. The only thing we require is tracking heart rate, sleep, and steps for the Fitbit data. So just kind of an FYI. And also with the health kit data that for the Apple users, we have a decent amount of people who have Apple Watch data in there. They use that instead of the Fitbit. So there might be some data you can do comparisons between the devices if you want, but just kind of an FYI, there's a decent amount of Apple Watch users in our study that use it exclusively. So just wanted to point that out.
That's awesome. Thank you. I mean, once these get used, if there's a couple views of prompt or of whatever is our next study that we expose in the tool, if there's views that aren't useful, we could take those out just to make it easier for the user. Or if there's better descriptions that you're like, this really isn't amount of time it took them to get out of bed. This is blah, blah, blah. We can just continue to iterate and make that more helpful. We love prompt because it was like such a great guinea pig for us to say, how would we, in a self-serve tool, show someone what's available in a hopefully clear way so you could decide if you wanted it for research or not. So prompt's been phenomenal to work with. But yeah, think about if you are working on a study, if one of the goals is to eventually make those data available for others to use. Think about playing with this and seeing how we could help expose it and link it with all the other types of data that we have right now.
So we have 10 minutes left. I'm going to stop recording.